Assalamu alaikum. This lecture will be about cord prolapse. Definition: cord prolapse is an obstetric emergency, might be defined as the descent of the umbilical cord through the cervix alongside or below the presenting part in the presence of ruptured membrane. Cord prolapse may be differentiated from cord presentation by membrane status, either ruptured membrane in cord prolapse or membrane was intact in cord presentation. 1% incidence is about 0.1% in vertex presentation, raised 1% in breech with frank presentation, and may reach 10% in foot limb breech. Breech presentation either frank, foot limb, or flex breech. I will attach an image to explain this risk. There are three clinical types of umbilical cord prolapse, either occult prolapse or cord presentation and cord prolapse. Occult prolapse, the cord is placed beside the presenting part and not felt during vaginal examination, either diagnosed by ultrasound or during cesarean section. Cord presentation, the cord slipped down below the presenting part and the membrane was intact. When the membrane ruptured, the cause would be cord prolapse and the cord lying inside the vagina or outside the vulva. Associated factors: first, malpresentation, the most common risk factor, then contracted pelvis. In contracted pelvis, the presenting part failed to accommodate lower uterine segment, prematurity, and low birth weight. Multiple pregnancy, polyhydramnios, placental factor, example low-lying placenta, and the cord insertion will be in the lower uterine segment. If membrane rupture, will be in a high risk to be prolapsed. Iatrogenic causes, example, artificial rupture membranes and not engaged presenting part, if the presenting part is not engaged. Fetal congenital anomaly, example, anencephaly, the anticipation and error detection. Patients in later stage of pregnancy who are at high risk of cord prolapse should be identified. The unexplained fetal distress during labor after rupture membrane, if the cord compress, will be presented as fetal distress and fetal tachycardia, then bradycardia and death. When suspected, perform speculum or digital examination immediately, as early detection is crucial for timely delivery and in the prevention of fetal morbidity and mortality. Diagnosis: rapid identification and management of cord prolapse may be life-saving to the fetus. Diagnosis: to diagnose cord prolapse, either by visual inspection or palpation of the cord. The cord may be coiled in the vagina or extruded outside or wrapped across the presenting part. The only sign may be a severe variable deceleration or bradycardia after rupture of membranes. Variable deceleration is one of the abnormal fetal heart rate tracing during cardiography, CTG, one of the methods of continuous fetal monitoring during labor. Prognosis: if cord prolapse, the perinatal mortality from asphyxia is due to either mechanical compression by the presenting part or the bony pelvis first, or by spasm due to exposure to cold weather, or by frequent manipulation. The prognosis related to interval between detection and delivery of the baby. Overall perinatal mortality about 15 to 50%. High mortality rate. Management: first, call for help. In any obstetric emergency, start by call for help. Call for senior obstetrician and midwife, call for anesthetist and neonatologist. Assess the fetal condition either by ultrasound or by fetal continuous fetal monitoring. Assess dilatation and status of labor. According to status of labor will affect the mode of delivery. Prevent further cord compression by elevating the presenting part. Prepare for urgent delivery, either cesarean section or vaginal delivery. The fastest one. Oxytocin should be discontinued and consider tocolysis. Type of drugs inhibit uterine contraction. After any emergency, don't forget documentation. What is the optimal mode of birth with cord prolapse? Cesarean section is the recommended mode of delivery in cases of cord prolapse when vaginal delivery is not imminent. to prevent hypoxic acidosis. A category 1 cesarean section should be achieved pairs within 30 minutes. It's emergency cesarean section categorization. There is 4 categories of cesarean section. Category 1, the top emergencies. Within 30 minutes should be achieved the pairs. Vaginal pairs in most cases will be operative. If the cervix fully dilated and the presenting part engaged, can be offered a chance of vaginal delivery, be operative vaginal delivery to be fastest and mainly by forceps, not ventouse. Vaginal delivery can be attempted at full dilatation if it's anticipated that will be accomplished quickly and safely. A practitioner competent in resuscitation of newborn should be attend the pairs, either vaginal or cesarean section. If diagnosed cord prolapse, attempt to prevent further cord compression by elevating the presenting part manually by the hand or by filling the bladder. The bladder can be filled by 500 ml normal saline to elevate the presenting part from the cord and prevent compression. Don't attempt to replace cord in the uterus. First, it's useless. Second, excessive manipulation can cause vasospasm. Place mother in knee chest or left lateral position. Sam's position, ideally with head slightly declined and arm below under the left hip, both to add the gravity to prevent the compression. This position may be adopted during transfer to theater or during preparation of cesarean section. Confirm fetal availability by auscultation of fetal heart using cardiography or ultrasound before cesarean section to prevent unnecessary cesarean section for a dead baby. This is Sam's position, left lateral position with hip flexed and below the left hip. In summary, management of cord prolapse can be summarized in a mnemonic of cord mnemonic. C. Consider cord prolapse in any abnormal fetal heart racing followed rupture of membrane. And at every vaginal examination in labor, without also after rupture of membrane in a mother with risk factor for cord prolapse. O stand for organized help. Call for help obstetricians and midwives, anesthetist and preoperative team, neonatal team. R stand for relief compression, manually elevate presenting part or by filling the bladder. Encourage into left lateral position with head down and bellow placed under left hip or knee just position. Consider tocolysis. D stand for decision of labor. Emergency transfer to hospital. If occur in a community-based situation, assess and assist birth by quickest means. Urgency of birth depend on fetal heart rate and gestational age. And viability طبعا, if baby viable or dead. If cesarean section, consider if regional anesthesia appropriate according to anesthetist decision. Thank you.